coming to the interpretation of LFT, as we all know, the LFT comprises numerous investigations. It starts with total bilirubin. You do have direct and indirect fractions on it. Then comes the liver enzymes, which is your SGOT and SGPT, which is your liver enzymes. And there is something called alkaline phosphatase, there is something called GGTP, and you do have a measurement of your synthetic functions, which goes by your serum albumin and INR. Now we will have a brief understanding of what are these enzymes, where they are coming from. So leave this total bilirubin. The indirect component of bilirubin comes from the breakdown of RBCs, which is the hemolysis. The direct component represents the conjugatory or excretory function of your liver. So that covers the bilirubin. Whereas the liver enzymes, as you can see, you do have something called ALT, AST and alkaline phosphatase and GGTP. These are the 4 enzymes. As you can see here, the AST and ALT, they are predominantly located in hepatocytes. The normal serum concentration of serum ALT is always higher than serum AST. Why is it so? Because the half-life is different. Your ALT half-life is 36 hours, whereas your AST half-life is close to 18 hours. So, even though both of these enzymes are present in the liver, from the duration of half-life, your ALT is always high. So, your ALT and AST ratio is high. And one of these enzymes is present only in cytoplasm, whereas the other one present in both mitochondria and cytoplasm. Coming to the alkaline phosphatase and GGTP, these 2 enzymes are present in something called biliary canaliculi. These are called biliary canaliculi. So when these enzymes are higher, either the GGTP or alk phos is higher, then we can assume that there is some problem in the obstructive or obstruction in the liver pathway, especially in the biliary canaliculi levels. So whenever there is a massive hepatocyte destruction, your AST and ALT can go up. Whenever there is a problem with the excretory or conjugatory function of the liver, your total bilirubin goes up. Whenever there is an obstruction, your ALP and alkaline phosphatase, that is your ALP and GGTP can go up. So how to interpret this? So total bilirubin is based on conjugation and excretion, and enzymes released by the liver caused by cell injury or death. This is caused by the biliary obstruction, and the albumin and INR, PTINR indicates your synthetic functions of the liver. Is there any specific pattern of your liver enzymes where you can diagnose certain conditions? Yes, but you can't diagnose a condition based only on this, but it can give you a clue regarding whether probably I am dealing with this. What is that? Usually, in case of liver pathology, that is, if you are dealing with something like acute liver failure, your liver enzymes should be more than 10 times the upper limit of the normal. And please to understand, usually. And so, if the ratio of AST and ALT is more than 5, we have seen that the ALT is slightly higher than AST because of the differential half-lives. This is 36 hours and this is 18 hours. In case, if it is more than 5, the flipping of the ratio happens, which means that there is a huge extra hepatic source of liver enzymes which is coming into the bloodstream. So, it can occur either from the cardiac or it can happen from the skeletal muscle. First thing. Second thing is, your AST-ALT ratio can be more than 2 in certain conditions like alcohol hepatitis, hepatocellular carcinoma or viral hepatitis. And if your ALP is, the bilirubin ratio is less than 4 and your AST-ALT ratio is more than 2.2, then probably we are dealing with Wilson's disease. And please do understand that this pattern of liver enzyme, the specific patterns and ratios of liver enzymes are never diagnostic. Probably it gives you a clue that it will subtly indicate probably I am dealing with this etiology of the acute liver failure.